You have permission now.
Thank you. Hello, everyone. Welcome to our second day of the PM3 workshop. So to start off, we have Ms. Randa Mudathir with her presentation on PM3 VCPL mouse.
Could I also have permission to record?
Given.
Okay, perfect. All right. Okay, good morning, everyone. As Lauren said, my name is Randa, and I am going into my fourth year of medical biophysics. And today, my presentation is going to be on the electroanatomical modeling of the heart, with a focus on how we're going to be using that to prepare simulations for arrhythmia caused by Timothy syndrome. And so before I get started, you guys are probably wondering why I have pictures of babies on my first slide. But actually, these are Timothy syndrome patients. And Timothy syndrome is a genetic disorder that while it causes cognitive and physical abnormalities, it also results in severe arrhythmia. And so that's what we're interested in studying and modeling, because managing arrhythmias is a very pressing issue in cardiology. And so if we're able to model the severe arrhythmias caused by Timothy syndrome, that would allow us to better understand the underlying disease mechanisms, and hopefully that has a positive clinical implications on how we can improve the patient's quality of life. And so before I delve into my presentation, I'm just going to give you guys a brief rundown on what I'm going to be talking about throughout my presentation. And so Timothy syndrome results in several cardiac alterations. Mainly it affects the heart in three ways. Firstly, it affects the L-type calcium channel. So it introduces specific mutations to the L-type calcium channel, which is an ion channel that is responsible for the depolarization of the myocytes. And so in clinical and experimental settings, this could be observed as a longer QT wave in the lead to ECG. And this is, you can actually see this in the figure on the right here in panel B. You can see over here that there's a longer QT wave in comparison to what it looks like here in a normal ECG. Timothy syndrome also promotes cardiac fibrosis. I will later on get into how exactly fibrosis affects the propagation of the action potential, but in clinical or experimental settings, it causes erratic electrical propagation, and this could be observed in optical voltage mapping experiments. Timothy syndrome also introduces mutations to IKR ion channels, which are potassium channels that are responsible for the repolarization mechanisms in the myocyte. And again, in clinical or experimental settings, this causes propagation, this causes wave propagation breakup, and this could be observed in optical voltage mapping experiments, but also in the ECG pattern. And so collectively, these three changes cause malignant arrhythmia that is often fatal to Timothy syndrome patients. And so first of all, I'm going to go into explain how the depolarization mechanisms are affected by Timothy syndrome. And so over here on the slide, I have a curve representing the current passing through the L-type calcium channel, which, as I said previously, is responsible for the depolarization mechanism of the myocyte. And so the curve represented by the black squares is the Timothy syndrome L-type calcium channel, while the curve represented by the black circles is the wild-type L-type calcium channel. And so as we can see over here, there's about a -9 millivolt shift in the steady state of the L-type calcium channel. And again, this is caused by a mutation that's induced. And so this shift indicates that the channel inactivation is impaired. And so this results in a prolonged action potential. And so keep that in mind as I explain what happens to the repolarization. And so the way Timothy syndrome affects the repolarization mechanism is by inducing a mutation into the IKR, which are the slowly activating delayed rectifier potassium channels. We're just going to call them IKR for short. But they are the channels responsible for repolarizing the myocytes. And so over here in the figure I have on the slide, the black curve represents the potassium channel just in a control group. So there's no mutation in that. And then the gray curve represents the Timothy syndrome potassium channel. And so we could see that there's been a downward shift in the curve. And so this indicates that we have a loss of function in the IKR. So our repolarization is being affected because our potassium channels are not functioning the way they're supposed to. And so in the previous slide, I mentioned that the depolarization is affected, prolonging the action potential, but here I'm also saying that the repolarization is affected. So this is completely messing with the timing of the action potential. Timothy syndrome also induces several structural changes that also contribute to the arrhythmia that Timothy syndrome patients experience. And so over here on the slide, I have the human sinoatrial node images of a young heart and an old heart. And actually the old heart on the left over here is actually a good representation of what the heart of a Timothy syndrome patient will look like. And so everything labeled in fat over here is actually fibrosis. And the way fibrosis affects the propagation of the action potential is that it reduces the side-to-side gap junctions between the myocytes, and that actually slows down the action potential. But fibrosis also increases the anisotropy of the heart muscle. And so these are all things that are affecting the natural propagation of the action potential, resulting in severe arrhythmia. The fibrosis induced by Timothy syndrome also results in a loss of cardiac fiber orientation. And the reason why this is important is because in cardiac tissue, the conduction velocity of the action potential is anisotropic, meaning that it is that the magnitude of the conduction velocity is highly dependent on the direction of the wave of activation. And so if you change the orientation of the cardiac fiber, you will be affecting the propagation of the action potential and the synchronization of the propagation of the action potential, again, contributing to the arrhythmia. And so this is where a little bit of my work comes into play. In the literature, there have been several models developed for the atrial cell, the ventricle cell, and actually Dr. Karsh developed a model for the sinoatrial node cell. And so what my work will be creating similar cell models for the mouse cardiomyocyte, but incorporating the ion channel changes that are exhibited by Timothy syndrome patients, so that we can have models that replicate the action potential propagation in Timothy syndrome patients. This is a bit of a digression from Timothy syndrome, but it's also something that's very important for us if we're trying to understand the underlying disease mechanisms of arrhythmia, and that's anatomical unevenness. So in the atria, we actually have pectinate muscles, which are parallel muscular ridges in the atria of the heart. And in previous studies and simulations, it's been observed that in the junctions between the pectinate muscle and the atrial wall, there actually happens to be a breakup of the wave propagation. And so again, including those in our models is incredibly important for us to properly model arrhythmias and better understand them. So over here is actually something that Dr. Karsh is working on. This is a work in progress with Dr. Karsh and a few of his colleagues. And so this is actually modeling the fibrosis mechanism of arrhythmias in the human sinoatrial node. So that green blob in the background is the sinoatrial node, and the action potential wave is supposed to be moving in a clockwise direction. But because there's fibrosis in the heart, that wave chirality is affected. And so again, this is something that's important for us to incorporate in our models. And so just a quick summary, Timothy syndrome is known to affect the depolarizing and repolarizing mechanisms by inducing mutations into the L-type calcium channels, as well as the potassium channels, the IKR potassium channels. Timothy syndrome also promotes fibrosis. As I mentioned previously, that slows down the action potential propagation and increases anisotropy. At the PM3 lab, we will conduct computational assessment to look into the consequences of these ion channel function changes, the structural abnormalities such as fibrosis, as well as the anatomical features such as the pectinate muscles that I explained previously. And I'm working on developing a three-dimensional mouse heart model, which I will then use to incorporate all of these ion channel functional changes, structural abnormalities, and anatomical features to replicate the heart of a patient of Timothy syndrome. And hopefully we could use that to develop a model for Timothy syndrome and study the severe arrhythmias that are caused by Timothy syndrome. That is the end of my presentation. I hope you guys learned something. Hopefully I didn't talk too fast, but thank you all for listening. And if you have any questions, please feel free to type them up in the chat and I'd be happy to answer.
Thank you for the excellent presentation, Randa. Much appreciated. So Riva has a question.
Yep.
Okay, so that was just a clap, but I actually would like to know what kind of motivated you to study Timothy syndrome as opposed to some other diseases that affect the heart.
So I think the reason why Timothy syndrome is it's worth studying is because just the severity of the arrhythmias. And I think if we're able to model such severe arrhythmias, that'll kind of help us understand other less severe arrhythmias. And so that's kind of the, yeah. Hopefully that answers your question.
I had a question. So you said at the end that you're working on a 3D model. I know that in the past, Sanjay has worked on some, 2D and just reduced order, reduced dimensional models. What's the advantage of a three-dimensional model for this, or just in general?
I think the advantage of the three-dimensional model is you get to see, because usually 2D models are just the atrial cell on its own, or the ventricle cell on its own, or the sinoatrial node cell on its own. Having the three-dimensional model, you get to see the effect of all three cells working together, and the way, so you'll be able to see the way Timothy syndrome affects the atrial cell and the sinoatrial node cell and the ventricle cell all at once. And so I think that's an advantage to using three-dimensional models.
Thank you for that, Randa. So just to add a little piece of information, Tim, as Randa's slide number 8 or 9 showed, we have working three-dimensional models of pieces of the heart and of the whole heart. So we have dynamic, electrically active human hearts working right now. The advantage of having spatially extended systems is that at the cellular level, as she said, you can reproduce experimentally observed early or delayed after depolarizations because of the protein dysfunction caused by her favorite disease. However, the complex behavior, the emergent behavior of the complex system, that is the waves, electrical waves going back and forth, does not come up till you have modeled it at least at a two-dimensional level, and all being well at three-dimensional level. Motivation for making 3D model is that Randa, all being well, will produce clinical measurables such as ECG, which you know where we can compare to data from experimental laboratories. One of the laboratories that you may wish to consider is a lab run by Alexander Quinn in our Halifax. And he runs optical mapping experiments on Timothy syndrome in mice. So that might be one of the motivations that Randa is running with.
Great, thanks both of you.